Welcome everyone. This is our second session of 2024 of the education series that the Colorado Coalition for the Homeless puts on. My name is Alexis Whittem. I'm the Director of Communications. Welcome. Thank you all so much for joining this evening. Today we're going to cover Homelessness 101 and accessing services. And to get started, of course, we want to go ahead and do a little housekeeping. For today's agenda format, today is going to be more of a presentation style. So like our last session, we are going to be presenting information to you. It's not quite a back and forth panel. The reason is that this is our Homelessness 101. We get asked a lot to give background, big picture information about homelessness. And so once a year, we like to try to do this and give everyone the latest statistics change, information changes, access changes. And so we like to update this once a year. And so this is going to be a very presentation heavy session. The beginning part, which I will be doing, will be primarily about national statistics, state statistics, city statistics, and then sort of causes of homelessness, and then, of course, what the coalition does generally. And then my colleagues will come on and tell you more about what the coalition does specifically. So if you are looking for more details on our resources and our work, that's going to be more at the end of the session. So just stay tuned. So the presenters today are me. I'm Alexis Whittem. I'm Director of Communications. And then later you're going to hear from my colleagues, Suzanne McLaughlin, who is our Manager of Client Access, that's specific to healthcare, and then Jacob Wesley, who is our Director of Outreach and Engagement. And so Jacob talks more about accessing services around housing. So we're going to go ahead and start really big picture. Let's talk about national homelessness. When we talk about national homelessness, we are looking at statistics. We're starting with statistics that come from what is called the point in time count. So the national homelessness statistic throughout the United States, according to the point in time count, is 653,104 people. The thing to know about the point in time count is it's a really specific way to do this count, and it has some flaws. First of all, it's only counting sheltered and unsheltered people, sheltered being people who are staying in a shelter, something of that nature, and unsheltered being typically people who are on the streets, maybe in a tent. We're not counting anyone who's in jail, anyone who's in the hospital that night, anyone who's at a motel, anyone who's couch surfing. This count is actually done on one night in January each year. And so it's a snapshot of a moment, but things change a lot, right? That's just one day. It's also volunteer-led, which means there's a lot of underrepresentation in rural communities. There are certain things that just don't get counted, but it is sort of the best system that we have right now, and it does affect funding. And so when you look at the funding for a state or for a city, they're going to look at this PIT count. It's just unfortunately like not accurate, and we think a very low count based on some comparisons that you'll see more when we talk about it in Colorado. Oops, sorry. So in Colorado, we're going to put our estimate between about 14,000 and 134,000. And I know that's a huge differential, right? If you look at that PIT count, it's going to say there's 14,439 people in Colorado. We think this is drastically low. We used to say it was probably about a third of the correct number. At this point, I would say it's even more far off from the real number. If you look at that 75,000 number, that's people who are accessing homelessness services throughout Colorado. That's 75,000 people. I would say that's probably pretty close to accurate because those are people who are saying, I need homelessness services, right? There's other numbers to look at as well as we do our comparison. Students experiencing homelessness, according to McKinney-Vento statistics, are around 18,000. And then if you look at the Medicaid number most recently, people without stable housing who are covered by Medicaid, it's 134,000. So there isn't a great count. We know homelessness is complicated. We know it's hard to count, and we know that the definitions differ. You know, here at the coalition, we say if you don't have a consistent place to put your head at night, you would be a person experiencing homelessness. We also generally serve people at risk of homelessness. So someone who thinks they might be getting evicted in a week or two, that person would be someone that we consider to be in our service profile. If we go even closer in detail at Metro Denver, their PIT count says 9,065 people. So this is that 7-county Metro Denver area, which is about half the population of Colorado. in 2023, we saw a 31.7% increase in this number. And of those people, about 30% are unsheltered and 70% are sheltered. One of the things I like to talk about when we talk about unsheltered versus sheltered is just there's a lot of rational reasons why a person might be unsheltered. It may seem counterintuitive to a housed person, but a person who is experiencing homelessness may not want to go to shelter because you can't bring your pets. Maybe you're recently evicted, you have pets, you can't bring them to shelter. So that would be a reason I'd rather stay in my car, stay in my tent with my cats or my dog. You can't often go to shelter with an opposite gender partner. So if my partner is of the opposite gender of me, we can't go to the same shelter. That's a reason I wouldn't go to shelter. Some people also maybe just don't like being in a big crowded space like that, right? So a lot of times people don't really necessarily know the reasons why someone might be unsheltered, but I think some of those reasons, we've talked about in past sessions, but explain why someone may, that we're going to have that 30% unsheltered for various reasons. If we look at racial demographics and homelessness, we're going to see overrepresentation by most people of color. This is once again for Metro Denver, this slide. So we're going to have 3.7 times overrepresentation for Black or African American folks, 1.6 times for multiracial, 3.6 for American Indian or Alaska Native, and 5 times overrepresentation for Native Hawaiian or Pacific Islander. As you can see in the graph on the very bottom of this slide, the population of people experiencing homelessness is still over half white folks, right? But proportionate to the population, it's a lower amount of people than people of color. And this is, of course, due to, historic reasons, people who, fewer opportunities, some of the things that we're going to have in the future of this presentation that I'll talk about, and reasons why people of color have been left out of housing opportunities in the past and still face a lot of discrimination. I also will mention that the LGBTQ population is overrepresented in homelessness, particularly trans people, and particularly youth who are kicked out of their homes. And people with disabilities are also overrepresented. You can find more in the MDHI report, which goes into lots of amazing detail on this. So next we want to talk about causes of homelessness. Here at the Colorado Coalition for the Homeless, we always start with systems. We start with systems because we think that is the reason that most people experiencing homelessness. But also that's what the data tells you, is that systems are what cause homelessness, not individual choices. There's a number of reasons here. For the first few, I'm just going to kind of touch on them really briefly, and we're going to go into more detail on the ones at the bottom. So generational poverty. I give this presentation to, fifth grade classes, junior high, high school. A lot of the analogies, a lot of the explanations I give there, I can give the same ones here for our mostly adult audience. Generational poverty, I just like to explain as, if your rent went up $200 a month, or the timing belt broke on your car, or you got laid off and you have a new job starting in 2 weeks, but you have 2 weeks off where you don't have an income. Do you have someone you can borrow $500 from? Do you have someone you can borrow $1,000 from? That is the difference between being housed and unhoused, is being able to access a little bit of money when something goes wrong, because things go wrong, right? Not having someone in your family that you can borrow from makes you more susceptible to homelessness. Family, friends, whoever your network is. Systemic and institutionalized racism. Redlining, not allowing some people to have housing is clearly a thing that we talk about, but we sometimes talk about as if it happened a long time ago, or it happened only in certain geographic areas. Systemic and institutionalized racism happens today, and there are people who individually, based on factors about their race or anything to do with their identity, are still not able to access housing. We really recommend checking out the book, The Color of Law, if you'd like to dig into that more. And we also know that it's complicated, right? Like people who are more likely to have been displaced in recent years here in Colorado and Denver are more likely to be Latino folks. We also know about this for Black African American populations. So systemic and institutionalized racism is definitely a key and something to touch on, but not something that we go to as much detail on in this presentation. Public benefit barriers and restrictions. Public benefits are available to people, but they're really hard to get. It's a lot of paperwork. One of the things we hear from our clients is how do I get that resource if all of the forms are online, right? A lot of people, I don't have a computer, I don't have access to getting online easily. They don't have a plug to charge in their tent, right? A lot of benefits are moving to online applications. That's hard. A lot of places will send you mail. It's hard to get mail consistently sometimes for people experiencing homelessness or people who are moving between addresses, right? It's also just really complicated to fill out a lot of these forms to get sometimes what is not a very significant benefit. So it's difficult to navigate our systems, and a lot of people are eligible and don't apply because of how complicated it is. And then, of course, access to healthcare and also medical debt. Medical debt leads to homelessness a lot. Losing your job because you had a medical condition is real. And if you're not doing preventative care, then you're more likely to have more incidents come up. So our organization certainly believes in the ties between housing and healthcare, and that's what the data shows, and it's important to mention. But today we're just going to focus specifically on a few of these that are very clear in the data, how they impact homelessness. So the first is wages. This is the hourly wage that you need to earn to afford a 2-bedroom rental. So here in Colorado, you'll see those darker colored states. Those are the most expensive places to live. Colorado is the 8th most expensive state in the country. About a decade ago, it was 19th. So we used to be about in the middle, and now we're up there, right? We're up there with California and Washington and Texas and places like that. Here, you need to make $32.13 an hour to afford a 2-bedroom apartment. That means if you're making minimum wage, you would have to work 94 hours per week to afford a 2-bedroom. Now, sometimes I give this presentation and people say, well, why do you need a 2-bedroom? You could live in a studio. Okay, sure, but this is an average, right? So one person might only need a studio, another person might have 3 children and they need a larger apartment. And so this is sort of an average of that. This wage is even higher in places like the Denver metro area or mountain communities that are expensive. This is the average for our state. And basically what that means is that 1 in 4 renters can't afford rent here. Minimum wage has gone up, but it just isn't enough to match that housing growth, the cost of housing growth. You're going to notice the same dark states there, the red color. It's the same places that were in the previous map, are the same states where there's just a deficit of housing. So this is done by NLIHC, and we'll have that in the notes. But basically what people are looking for is affordable and available rental homes for every 100 extremely low income renter households. So I know that's a lot of words. Let's break it down a little bit. Affordable, it's a something you can afford at your income. Available means it's available to you to rent. And then it's for every 100 extremely low income renters. So extremely low income renters are essentially people who make 30% of the area median income or less. So in Denver, a single person who is at 100% area median income or AMI makes $73,360 a year. In Denver, a person who's at 30% AMI makes $22,050, right? So let's take a look at this graph on the right there. If you are at 100% AMI, you're getting that $73,000 a year. You go to 100 of you go to look for housing. There's 101 affordable and available units. So you can basically find something. When you drop to 80% AMI, it's a little tougher, right? For every 100 people looking, there's only 91. But it's really the people who are at 50% AMI and 30% AMI who have the hardest difficulty finding housing. And so if you're at 30% AMI, there's only 27 affordable and available units for every 100 people who are looking. So when I explain this to the 5th graders, we talk about a game of musical chairs. And there's basically 2 or 3 chairs for 10 people who are looking to get a seat, right? And so before anything about that person is taken into account, anything about their race or their ability or anything like that, we're already just in a state where we're playing a musical chairs game that we're losing. And that's the most important factor. A little bit more about housing affordability on these next couple slides, just to like show you the data behind this. Studies find that every time there's a $100 increase in rent, homelessness goes up 9 to 15%. One study said 9, one said 15. Neither of those studies were in Colorado, but they were done in the United States, and those are numbers that we have. In Denver, home prices rose $94 a day between 2012 and 2022, 162% increase. So what this means is not only is it incredibly hard to be a new renter, it also means that maybe, let's say you're a renter at that 80%, 100% AMI, and you were going to save up and buy a place and get out of the rental market so the more could be available. You probably got priced out the last 10 years, right? And so there's a bunch of people who are in the rental market who don't want to be, who are stuck there because of how high prices of homes are. And I know anybody who's watching this is saying, yeah, I know. Like anybody who lives here, we know this, but the stats are really good to understand how it relates to homelessness. Denver housing is 36% higher than the US average. Another interesting thing to note is that there are over 22,000 empty units in the Denver metro area. So you might say, hey, we've got, you know, 15,000, 30,000, 70,000 people experiencing homelessness. There's all these empty units. That would be great if we could just get those correlated. Unfortunately, most empty units are luxury units. Um, it is not incentivized for people to necessarily lower their rent and get someone in sooner. People can write off a loss for having an empty unit, and so a lot of units stay empty where the landlord will just wait till someone can pay the rate that they're trying to get, which is usually way higher than someone at 30, 50, 80% AMI could do. It's also just important to note that there's a lot of doubled up families. This is just a statistic where we just see that there are a lot of people who are avoiding homelessness and able to stay housed, but they're doing it by being too many people in too small of a space. And so it's just grown exponentially over the last few years. This is a really amazing study that just further digs into this by a professor at the University of Washington's College of Built Environments named Greg Colburn, who worked with a data journalist on this. Essentially, what they wanted to look at was those things on the right side, factors that people say explain homelessness, right? They'll say everyone who's experiencing homelessness is mentally ill. Everyone's using drugs. Everyone is just deeply in poverty, and it's just about poverty. It's not about housing. People move to places like Colorado or California for climate or because they have generous services. No, they did the study, and essentially they looked at the correlation, and the correlation with homelessness is related to housing market conditions, including median rent, rental vacancy rate, high population growth versus low supply elasticity. And that's where the correlation is. Another thing to note is just federal level disinvestment. Prior to 1980, almost all affordable housing development was partially or completely federally funded. 1980, for those of you who recall or maybe learned it in history, was the Reagan era, was when the Reagan era started. And we basically saw just stop of building affordable housing. So this means you're leaving it up to the market, right? The free market. And what the free market does is it builds luxury housing. Nationally, most new construction since 2014 has been in the top third of rentals, while only 6.6% has been in the lowest third of rentals. We know that low-income people are not 6.6% of the population, but only 6.6% of the houses we're building are for low-income individuals. We also, once again, see that same benefits problem that I mentioned earlier, that the Housing Choice Voucher Program just people don't receive vouchers at the level that they need them because of how complex it is. And then people who do have vouchers experience discrimination and an inability to use their vouchers. There's also interesting statistics about federal level disinvestment of just keeping up properties. So we also see that some of the properties that do exist are really old now, right? Because that's when we built affordable housing, was before 1980. So it's all 40, 60, 80 years old. And so sometimes housing goes off the market and is no longer available because it's in disrepair and we're not building enough to replace those. We also talk about criminalization. People want solutions to homelessness, and some people really want that solution to be criminalization. Unfortunately, it's not only inhumane, it is also just super ineffective. So here in Colorado, we have 350 anti-homelessness ordinances in cities and towns. The way those laws work can range from anything from camping, sleeping, lying down. There are places where you can't bring food to someone, or certain just very strange rules. And a lot of them are things that would be legal if you were housed. So let's say that it's opening day and I go over to Coors Field, and I have a beer outside the stadium. I don't think it's very likely that me personally that I'm going to get a ticket for outdoor drinking, but someone who's in a park is likely to get a ticket for that, right? Someone who's experiencing homelessness is 11 times more likely to be arrested than someone with housing, and they're often arrested for things that would be legal if you were housed. They're not really breaking a law that is a general law. It's a law because they are unhoused. Um, and then when people get picked up and they end up in jail, it has a lot of consequences to them, right? 40 to 50% of people experiencing homelessness report having income in the year of their homelessness. So that means that half the people out there experiencing homelessness have a job. If you get picked up and you're in jail, you might lose that job, right? Because you weren't able to go into your shift, you weren't able to figure it out. Maybe you had an appointment to get signed up for housing or to get signed up for benefits, or with your children you were going to do XYZ. It really disrupts people's lives to be arrested, and it also just adds more to try to pay money to get out of jail when you were already arrested for not having money essentially and experiencing homelessness. Camping bans also just simply create mistrust between law enforcement and unhoused people, and sweeps also do so. We know that sweeps are really terrible for our clients. People have confiscated or lost property. They have sleep deprivation. A lot of people lose their paperwork or their medications in a sweep. And so it just ends up being really bad for folks. And also, of course, can lead to injury from exposure as well. So we do touch on personal barriers. It is not nothing, and we do mention them. They're just not as important as those structural barriers, right? So some of the personal barriers that are relevant: mental illness, job loss, eviction, physical disability, family breakup, domestic violence, and substance use disorders. So domestic violence is the number one reason that women experience homelessness. It is certainly noteworthy and something that we reference. But if you're experiencing domestic violence and you can go rent another apartment for $600 after you go to leave your partner, that's a lot more accessible, and you're much less likely to fall into homelessness than when the market looks like it does, right? Also, mental illness, job loss, eviction. Most of us who are housed know people who experience those things and are not experiencing homelessness because they don't have those other factors. The one thing that is about individuals that we do like to mention is adverse childhood experiences. It's not a personal barrier in the way that people typically think of it, but it is something that's unique to people that we like to mention. Because we are a healthcare organization, it is relevant to touch upon. So adverse childhood experiences essentially are traumatic events that happen in your childhood years around violence, abuse, neglect. They end up having lifelong consequences for people who experience them. So toxic stress from ACEs can negatively affect brain development, immune system, stress response systems. It's linked to a high number of ACEs. So essentially you take like a 10-question quiz, and the higher your score is out of 10, the higher your ACE score is, right? Linked to chronic health problems, mental illness, substance use problems, barrier for relationships, work, etc. It has a connection to homelessness, right? That's a data point. So if you look at this purple chart here, you can see the number of ACEs and the correlation to homelessness together. So essentially, once you have 4 ACEs, that's when it starts to go up more significantly. A lot of our clinical staff tell us that they're not giving ACE quizzes to a lot of our clients. They just assume people have a high ACE score because so many folks do, but also that pretty much everyone we're going to work with is going to be traumatized because the experience of homelessness is traumatizing. So whether you have an ACE score and trauma in childhood, you're going to experience it as a person who's an adult who's experiencing homelessness because it's a dehumanizing and terrible experience. And so we're going to always be doing trauma-informed care when we do our work, and that'll be part of what we talk about later in sort of our. So I know that's a lot and very heavy, but we now can talk about sort of what do we do to combat homelessness, right? So we sort of think about 2 things. We think about emergency services and long-term stability. And the coalition works on both sides of these circles, right? But we try to work more towards long-term stability when possible. but everything is necessary, right? Like we need a cold weather network to respond in the cold and make sure people are safe and alive through our winter storms that come and go. We know that people need food bank, they need food security. So we cover all of this, but as I now like dig into talking about the coalition, we'll hopefully be talking a little bit more about long-term stability. So we essentially do four things here at the coalition. You'll notice in the bottom left, we got our new little logo, and I have a new background here because we're celebrating our 40th year. And so we, for 40 years, have been doing a number of things. We've been doing housing, healthcare, supportive services, and advocacy. We actually opened in 1984 doing healthcare and just realized that tie between healthcare and housing was really necessary, and other elements have grown from there. So housing, we have 23 properties, and on any given night, we serve essentially 4,470 people have a roof over their heads, thanks to working with the coalition. About half of those are at our properties, and about half of those are through vouchers. Our first property opened in 1996. And yeah, we're always kind of adding more in to meet the needs. But when we talk about our housing, we're talking about a really specific thing. We talk about housing first, but not housing only. So essentially, housing first model means the solution to homelessness is housing. It is housing above all else. People may need other supports. They may need help with job assistance. They may need help with a mental health condition. They may need help with childcare. But the first thing that they need help with is housing. And so what we do is we use the housing first model, which means you give people housing first, and then you work on everything else. But it's housing first, it's not housing only. And so that means that what we have are wraparound services that support individuals who are at our housing, right? They're going to have on-site case management. One of the cool things is if you're in one of our properties, the same case managers are on site all the time on that one property. So it's relational. You're going to know the person who's your case manager, and you're going to know as a case manager who's in your building, right? Case management, counseling, substance use treatment, psychiatric care, medical care are all part of our permanent supportive housing that we have. And that means that, yes, our housing is, you're meant to stay permanently and you're meant to have those supports throughout time. People typically do pay rent. They pay about 30% of their income. So that may be $0 when they move in, and that may grow over time as that person stabilizes. We have plenty of people who live in our housing and have been there quite a long time. We have many people at the Forum apartments, which have been there since 1996, who were original residents in 1996. We also know that there are proven outcomes for permanent supportive housing success. So people who believe in treatment first models, it's just not in the data as successful. Treatment first being for a substance use disorder, it's just simply not as successful as housing first solutions. We also know that there are proven outcomes for something like the social impact bond. So that's what that means there, where it's a SIB and CIPRA. The social impact bond essentially was an initiative to figure out if we could do sort of a controlled study with a number of private, government, nonprofit partners to see if giving people housing first, the people who are the highest utilizers of services in Denver, so maybe that's jails, that's hospitalization, that's emergency services, finding a list of those, doing a controlled study that we didn't control the data of, the Urban Institute controlled the data of, and then comparing the people who were in the housing program and the people who didn't get that. And what we found was that 80% retention rate after 3 years, 50 to 70% reduction in arrests, 25 to 35% fewer ER visits, and also increased primary care visits. And so essentially, housing first works. It also saves money. Services provided are essentially like the coalition can provide supportive housing and services for about $13,400 per person annually, compared to the $21,000 to $40,000 costs for taxpayers for medical care, incarceration, detox treatment, shelter services, etc. So once again, we're making a data-driven choice when we do permanent supportive housing through Housing First, but we're also doing the humane thing, and that is great that those are the same, that the system is the same. Our housing is interesting. It differs depending on, we meet lots of different needs in housing. So just a couple examples, we have specific veterans housing. We have something like Fusion Studios, which essentially like converts a hotel. So that can go up a lot quicker than a brand new building, right? And then we have Legacy Lofts, which is a dedicated space that's built above a healthcare center. So we're really trying to use space wisely in Denver when we have projects. How do we convert something? How do we build up? Next is healthcare. So Suzanne will tell you more about healthcare. I'm going to give you just sort of an overview. Um, in 2022, we served about 14,000 patients. We are still waiting for our final number for 2023, but it was closer to 17,000, I believe. We have seen a large increase in patients being served. A lot of that is due to an influx in migrants, we believe. And just a reminder, the next month we're going to cover serving the migrant population and the correlation with homelessness. So please register for that one if you want to learn more. But we would say, we normally say we serve about 15,000 people a year. I'd say it's closer to 17 now. Homelessness and health are just, once again, important to understand how they correlate. Homelessness is associated with a 15 to 30-year reduced life expectancy. What our clinicians tell us is if I have someone who comes in who's 50, who's been experiencing homelessness for a while, especially for a longer period of time, I'm going to look for conditions more like associated with a 70-year-old than a 50-year-old because it's so hard on the body. It's hard on your stress. It's hard on you physically with weather changes, with being on your feet a lot to experience homelessness, that it just literally leads to reduced life expectancy. Part of the reason for that is also that people experiencing homelessness have an increased likelihood of experiencing violence, risk of traumatic injuries and assault, and then, of course, exposure to extreme heat and cold. And what our doctors tell us is if I could prescribe housing the way I do medication, I would. We're starting to see some pilots that are getting us closer to this maybe being something that can happen where there's real medically approved housing. There's a pilot program called Swishy we're very excited about, but we still are not quite there yet. And lots of things in our healthcare system to work. One thing we like to highlight about our healthcare is a new building that we have, which is the John Pervinsky Stout Street Recuperative Care Center, which essentially is the bridge between when someone's ready to be released from the hospital and they're well enough to go home. What do you do if you don't have a home? What happens is you essentially end up being readmitted to the hospital in all likelihood within 30 days because you could have something very serious like toes removed, chemotherapy, heart stent put in, and then you're going to go sleep in a tent or sleep in a crowded shelter. Some shelters won't even let you in if you have certain needs that physically, and it's just very hard to keep your wounds clean and to I mean, many of us have been released from a hospital and know that the last thing you would want to do is be outdoors in that situation, right? So what the Recuperative Care Center does is it sort of bridges that gap and it allows a place. We have 75 beds for folks who are released from the hospital to come and stabilize with us during that period of time. You can learn more about it on our website. It's a really amazing program. And if anyone works in the sector, there is a form to fill out if you want someone to apply to go in. They do have to have a medical referral, and most come from hospitals, but not all. Supportive services, we just call this everything else. These are all the other things that help support people who live in our housing or people who are our clients. So that includes our outreach that we do direct to folks. It includes family support services. We have a child care facility at Renaissance Children's Center that's celebrating its 25th anniversary tomorrow. We have a lot of employment programs, a lot of opportunities for people. One of the ones that we like to talk about is Fort Lyon, which is essentially a facility in Southeast Colorado where people can stay for 3 months to 2 years to work on their recovery. We had a substance use disorder ed series, I think about a year ago, and had our director of Fort Lyon in that. If you want to learn more, you can watch that one or read our 10-year report. But Randy can also tell you about it. Randy's in this slide who we love. Randy is a reintegration specialist at Fort Lyon, which means he helps people when they're done with how long they needed to recover there. They're ready to be integrated back into community and move outside of the facility. He helps them with that. He also was a client. And so that's one of the reasons Fort Lyon's so great is that there's a lot of staff who have lived experience and really understand what it takes for substance use recovery. And so anyone who's listening and also wants to apply for that, there is an application online there as well, and you can contact them for more information. Finally, advocacy. Essentially, we're going to work on the national, state, and city level to try to make policy changes, the kind of comprehensive, large policy changes that can really impact some of those big picture issues that we're talking about that create the system for homelessness, right? Create the housing problem, healthcare problems. We have an advocacy network that any of you can sign up for. Go to coloradocoalition.org/advocate, and you can be part of our lobby day we just had a couple weeks ago. You also will just be in our network, so we'll say, hey, write your representative and tell them to vote yes or no on this, because it'll help people in our community. So please do join us if you'd like to. We basically concentrate on housing, renters protections, healthcare. Those are the main bills we're looking at. We're also looking at economic stability. So lots of opportunities. There's always a lot going on. We have some bills this year really specifically that we're keeping an eye on or testifying on behalf of or against. And if you want to know more about that, I would check out our YouTube page. We did a whole session last month on what's happening in legislative session. So with that, I'm finally going to be done. I'm going to pass it to Suzanne, who's going to tell you about accessing services specifically around healthcare, and just a little overview of what we do. And then when she's finished, we'll go ahead and pass to Jacob. So Suzanne.
Hi, I'm Suzanne. I'm one of the managers of client access here at CCH. I wanted to talk a little bit about our healthcare services today. Next slide, please. Thank you. So CCH is an accredited patient care centered medical home, which means that we provide a diverse set of integrated services surrounded and centered around that physical and mental health care needs that our patients need. We aim to be a one-stop shop where we can make transitions between our services to be as seamless as possible. So for example, when a patient comes in and sees a primary care physician, we can do a warm handoff in the moment with a behavioral health provider or a case manager. We have a MAP walk-in program, which reduces barriers to care. We also assist our clients in navigating any services needed outside of CCH. So we have a group of care navigators that assist our patients with referrals for specialty care. We also have an enrollment team, which helps our clients enroll in Medicaid and allows them to be able to have those referrals sent out to other places and get their care needs met. Next slide, please. Thank you. So Stout Street Health Center is what we call the mothership. This is where we see most of our patients and where most of our services are held. We have a satellite site at 48th, which is a shelter-based healthcare site that is inside of the Denver Rescue Mission. One of our primary mottos of meeting patients where they're at. We have the HOP, which is our health outreach program. It's the same philosophy as 48th. And despite of being inside of a shelter, it is open to the public. The HOP is our medical mobile vehicle-based program that goes to sites around the Denver metro area that serves the homeless population. And I'll talk more about that on this next slide. West End Health Center was closed down for 2 years during COVID. It is a smaller, calmer site that generally has lower wait times to see primary care. We also provide pharmacy services there. And then this past year, in 2023, we opened an OB and prenatal clinic there on Wednesdays to serve our prenatal needs for our patient population. And West End, like I said, is dedicated to this every single Wednesday. Fort Lyon is a recovery community. That site also has an on-site health center that provides primary care, behavioral health, and substance use treatment. And then again, SSRCC, the John Pervinsky Recovery Center. It should be noted that that recuperative care center does not take referrals from the public. Referrals must come from a healthcare provider or a healthcare affiliated community partner, such as some of our local hospitals. Next slide, please. So this is our health outreach program. This is our mobile medical vehicle that goes around the city. The HOP fills a critical need for people experiencing homelessness. Many of our patients are unable to access traditional healthcare because of barriers like transportation or because they're simply too sick to go. The HOP works to reduce these barriers by meeting our patients where they're at and treating them with respect. We provide a full range of primary and urgent care services, And this program also reduces the strain on the emergency departments where many of our patients go to seek that healthcare. So right now, our healthcare outreach program is going to 6 sites, which 2 day shelters and 1 men's 24-hour shelter. And then we're also going to 3 of the micro communities, some of the hotels that the mayor has opened with his new homelessness initiative program. Next slide. Thanks. So how to schedule with us. So check out our website. It has most of our recent up-to-date days and hours of operations for all healthcare center locations. We are operating a wait list. Over the past couple of years, Stout Street Health Center has experienced a sharp increase in demand for medical and dental services from new patients who we do not have an established relationship with. So this surge of demand from new patients reached the point where it became difficult for our established patients to access our services and dental care patients to get in for appointments. As primary care medical home model health center, continuity and quality of care is the utmost importance to us. Because of these factors, we made the difficult decision to implement that wait list for our medical and dental services only at Stout Street Health Center. So for new patients, they'll come in, they'll fill out a pre-registration form, they'll be placed on a wait list, they'll meet with our enrollment team, and then we'll call or email them, depending on their preference, when it's their time to schedule an appointment. Next slide, please. Some frequently asked questions that some of you may have. What do you need to get services? We strive to provide low barrier access to care. New patients should bring a photo ID and a copy of their insurance card if they have it. But either way, we're going to see them. If a client is uninsured, we have a team that can help them enroll in Medicaid and other state programs, or refer out to our partner organizations to apply for Medicare or marketplace insurance if those clients are eligible for that service. Are services available for children and teens? Yes, they are. Services are available to them. They must be accompanied by a parent or legal guardian. And we run a pediatric medical clinic every Tuesday. There is currently a wait list for this. The first Wednesday of every month, we also provide integrated pediatric care, including medical, vision, dental, from 4 to 6 p.m. And what if you're undocumented? We will still see you. If you are undocumented, we are happy to care for you regardless of your insurance or your immigration status.
Thanks so much, Suzanne. And yeah, we'll hand it over to Jacob. Thanks.
Hey, everybody. As Alexis said earlier, I'm Jacob Wesley, the Director of Outreach and Engagement at the Coalition for the Homeless. I really think it's so perfect to follow up Suzanne, because really, I kind of look at both of our parts of the organization as really the front-facing parts. So if somebody walks into any of our buildings, it's going to be someone from our department in outreach and engagement or their health services that's likely going to be the one who serves them. So I'm really excited today to kind of get into more details and go over all the services we offer. So you're going to see some different program names. You might see community resources, path, outreach listed. That's not really that important to keep track of here. Really, the thing to keep track of and to think about is that this department is here so that when someone goes to the health center, let's say they're seeing a doctor for, maybe some diabetes that they need help controlling. If they're talking to the doctor and they're saying, well, it's really hard, I'm in the shelter, the food they serve isn't always the best, what the doctor is going to do is they're immediately going to do a consult request for a case manager, which is somebody from our department. They're going to go in the room, they're going to talk with the person, they're going to go over different food options that they can potentially connect them with. And more importantly, in the long run, they're going to do different housing related case management to help them get into permanent housing, to help them get into a situation where they have more control over various aspects of their life and their health, right? Not just that one food piece, but that's just one example of how our departments both work together and of how we're providing resources. So really, I think it's more important to keep track of the services I talk about more than the program names themselves. But overall, whether it's the community resources program that's listed here, our outreach workers who are out on the street, What we're doing is a general, pretty consistent set of case management. Most, if not everybody, wants to talk about applying for permanent housing. Many, right, need more like urgent services, so they might need shelter information. They might have immigration issues that they're struggling with. We do a lot of replacements with immigration cards and different documents like that. We're able to try to help them get the fees waived oftentimes. People will come in, they don't have any benefits, but they qualify for Medicaid, food stamps, different disability benefits that are out there. We help them apply for those. And then, it says basic hygiene products. I mean, that's true. And this time of year, what's more common is whether we're out in the streets in cold weather or people coming to our office, hats, gloves, socks, all the stuff that they need to kind of stay warm. And then advocacy is, I think, honestly, one of the best things we do. So we've had clients right now say that they're really struggling with Department of Human Services, sometimes with their benefit applications. They're submitting them on time, but they're not getting processed, they're getting denied. And so we're working both with the client and with our education and advocacy team to try to raise those problems to a higher level, to try to get those issues solved, not just for those specific individuals, but for all people who are using those benefits for that particular example that I gave. So housing case management, this gets its own slide. Again, this is by far the most common, service that we're trying to provide people with. Section 8, I always put this on here because it's, in my experience, when it's communicating with different people who aren't in social services, this is the type of housing that they're familiar with. They've heard Section 8. Essentially what Section 8 means, it's not really a term that's used by the housing authorities and different people that issue that type of subsidy anymore. Really what it just means is a voucher that somebody has that they can take to various different landlords. It doesn't have to be a property that's set up to specifically work with Section 8 vouchers. All landlords legally have to accept them. That was one thing our education advocacy team really played a big role in locally, was making sure that landlords all had to accept those versus rejecting people with housing vouchers. And when you have one of those vouchers, what it means is you pay 1/3 of your income towards rent. That's really common. You're going to hear me say that a few times, but it's really nice. It's for life. You can port it to different cities, even different states. I had a client that I was working with for years. A couple years ago, he moved to Oregon. We got his voucher ported to Oregon, and he was making $1,000 a month on disability payments, so he was paying right around $300 a month for rent. And there was an issue with his benefits. They were cut off for a couple months, and so he didn't have to pay rent those months because, right, 30% of nothing is zero, and that's why it's such a great type of housing to get into. It's also really difficult. You have to do different lotteries with different housing authorities. And so, right, so for Denver Housing Authority, it opens up pretty much every September for 2 days. People can put their name in for the lottery, and then they pull names from that lottery for the next 12 months to see if anyone gets one of those vouchers. It's pretty slim. It's usually about 1 in 100, 1 in 150 who get that. So low-income housing tax credit, or if you want to sound really cool, you can say LIHTC. That's like the lingo for it. This is what a lot of our buildings are set up as. So LIHTC essentially is a little bit different. You have to make below a certain income to qualify, but the rent doesn't change based on your income. That 30% thing I talked before, it's just a rate that's far less than fair market value. So a lot of fair market value in today's crazy housing prices, monthly rent could be $1,600, $1,700. And at one of our properties, it would be more like $800 or $900. There's a lot of different calculations that go into what that exact rent is, and I don't pretend to fully understand all of those, but it is a pretty significant discount off the market rate. HUD 202s and 811s, this is what I would kind of lump into, just for ease of use, kind of the category of site-based Section 8. So the idea is a whole apartment complex is set up to charge that 30% I talked about before. The requirement for this is typically that you either have to have a disability that prevents you from working or prevents you from working full time, or be 55 and older. For some properties, more commonly is 62 and older. So essentially have a disability or be a senior. And then that entire building is set up to charge you 30% of your income once you get in. The downside to this one is waiting list. So it's anywhere usually from 12 to 24 months to get somebody into one of these properties. We fill out literally thousands of these applications a year. And this isn't really important. It just kind of breaks my heart. They're still 100% on paper. And because it's government subsidized housing, they're about 50 to 75 pages. And so we're just killing trees left and right. And it absolutely kills me to do that. And they just haven't gotten to the point where it's all electronic yet. So we're mailing off just literally thousands of giant packets of application materials every year to different housing complexes on behalf of our clients. And then for permanent supportive housing, this is like what I would call the Cadillac of housing. CCH is huge on permanent supportive housing. We believe it is vital to any long-term strategy to effectively combat homelessness. And, you know, I know Alexis already went into it earlier, so I won't go into it too much in depth, but just to recap, it's housing, very much like I talked about before, we're charging you 30% of your income. And the big and is it comes with supportive services. So it comes with a case manager, it comes with a behavioral health person. Some teams, it even comes with medical support through a nurse, even sometimes a psychiatrist. And so we love that type of housing because then it helps you stay housed. Right? Sometimes things happen outside of our control. Maybe someone's been in housing for a couple of years, they're doing really well. Maybe they had a change in medication and they had a bit of relapse in mental health symptoms. Having that support there helps prevent them from experiencing homelessness again. And getting into it is a bit of a weird matrix, but really the way it works is through this thing called coordinated entry, which if you go to mdhi.org, it talks a lot more about. But essentially, you do this this questionnaire with people, and yeah, you can see the very complex matrix it goes through here. It's supposed to make it easier, but going through coordinated entry, it still does get confusing. But you go through a variety of questions, and essentially, the more vulnerable is their word that you come across by the way you answer those questions, the more likely you are to get matched with a permanent supportive housing resource. However, it's not a waiting list. And so I've done probably in the range of hundreds of them now over the years. I do less nowadays. And those ones I did years and years ago, it's not like those people are going to come up on a waiting list at some point. The people who haven't been selected just didn't score high enough, so they're never going to be selected. So it's a really imperfect process. It's not MDHI's fault. It's not CCH's fault. It's really a supply and demand problem. You have thousands of people in the Denver metro area who need permanent supportive housing, and typically only hundreds of units that come available every year. So that's what makes it really tricky. So how to access our services, really, if somebody walks into any CCH property that includes our properties, that includes any of our downtown campus buildings, and they say, hey, I'm experiencing homelessness, I'm staying in the shelter, I'm sleeping outside, you know, where can I get services? They're going to refer to here to the walk-ins at 2100 Broadway. That certainly is a really good way to get connected. Again, we have a huge supply and demand issue. So right now it says we have 10 new clients. We can intake about 40 new clients a month into the program. And we have about 4 to 5 times that show up seeking services. Again, it's just a supply and demand issue with having a right number of case managers to be able to serve everyone we want to be able to serve. The good news is we don't have that same issue at the health center. So what we really do encourage people is if they have any type of health needs, even if it's just preventative, we love to do preventative care with people, go to the health center, because the case managers there that work with people who are engaged in the health center actually do have more immediate capacity. And so we are able to see people again right away on a consult and then schedule them for a longer appointment to go over all of their housing and different case management needs. So again, you can either go 8 a.m. at 2100 Broadway on Wednesdays, that's for singles. Families can go Mondays at 8:30, and really any day, Monday through Friday, business hours, to the health center. And Suzanne went over all that information before, so I won't get into that. But again, it's through those appointments that someone can also get connected to a housing resource. And then there's other information here in terms of contact, like phone number and email address, that can be helpful for people depending on their preferred mode communication.
Thanks so much, Suzanne and Jacob. Well, we've hit the Q&A part. We've got about 15 minutes for it. So I'll take a look at what's happening in our Q&A section. If you've put something in the chat and you can move it to the Q&A, please do. That helps us, those of us who haven't been able to be in the chat because we've been talking, to make sure that we see the questions. But before we do that, I'll just start with Jacob and Suzanne. I don't know, I had a very long presentation. Is there anything in there that you think was wrong? Is there anything you think we skipped over? Is there anything that surprised you? Like, we always like to ask our sort of panelists who work more closely with clients than we do, who build these presentations. Yeah, any thoughts on that, or things that you think were missed, maybe that people need to know?
So there's different trends that happen year over year with the demographics among those experiencing homelessness. The one constant during the 18 years I've been doing this is that people of color are disproportionately represented in that group. And, I think any type of really good long-term strategy, again, needs to address that. I always see that as more of an upstream problem, right? And Alexis did a great job of talking about how that's right, a systemic racism issue, which we could get into, and that's a whole other presentation in and of itself. I just really like to emphasize that piece that, right, while these numbers, you may see them change, the number of people experiencing unsheltered homelessness versus sheltered, families versus singles, that stuff does change a little bit year over year, but what I talked about before doesn't really change. One thing we're doing was we do have a Native American Services program in our department. It's the only culturally specific programming we have. And the idea is that because people who are Native and Indigenous are experiencing homelessness at higher rates, we do have folks who are Native and Indigenous themselves as staff members who are running different cultural specific programming, including talking circles and other different types of events to support people specifically the way that they've communicated to us that they need support, and that supports them culturally as well as their needs regarding their homelessness that they may be experiencing.
Thanks, Jacob. Great. I have some questions here in the Q&A, and Suzanne, if you think of anything later, just jump in to correct or change. This is a very specific one. It's Tom wants to know how I can find how many non-related individuals I can house in my home in unincorporated Aurora. I think it sort of leads to a larger question, which is like, if someone's generally looking for answers for something about housing and homelessness, and we talked a lot about our organization, but like, where do you all recommend that people go to maybe answer one of these outlier questions or get information that's not in Metro Denver? Are there resources that you would recommend?
I mean, that's a great question. We generally refer people to 211 as like a good general, just like, because as you can call it from anywhere, right? Any phone, you get 211, it goes to Mile High United Way. They keep an updated list of resources. We do our best as well, but I'll be honest, maintaining an update on resources is really a 24/7 job. In that huge snowstorm we had not too long ago, right? All the resources changed just for those few days. And while our outreach crew and a bunch of our staff stay up to date on that, we do want to make sure people can call and always get up to date resources. And really 211 is the best. That's a very specific question. I love it because it shows such a strong desire to help. And right, it's a very local specific issue. Hopefully 211 can refer you. My guess would be either the local housing authority or someone like that might have more information on that. I wish I did, but yeah, I don't have too many specifics on that question, unfortunately.
Thanks. We have a question. It's can we talk more about mental health services at CCH? I will mention we're going to do a dedicated session on mental health and homelessness in our May education series. So we just put that up. I think that's happening. But in the meantime, Suzanne, do you have an answer to that about mental health?
Yeah, like I said, our primary care physicians and our behavioral health providers and psychiatric providers work hand in hand. So we really try to emphasize doing those warm handoffs at the time of that care happening. We do provide psychosocial and diagnostic assessments, brief counseling, psychiatry, wellness classes and groups, individual therapy. They do medication-assisted treatment and specialty care referrals.
Great. Thank you so much.
Yeah, and I just really quick, Alexis, forgot to mention before, all the resources I talked about, right? People being out in the street, people being in the office at 2100 Broadway, obviously the health center, they have access to what Suzanne just talked about. We have behavioral health professionals paired up with those groups of people. So we have them out on the streets, we have them in our office at 2100 Broadway. And the idea is when someone comes for one of those intakes, that they're also not only just screened by a case manager for their service needs, but they're also screened by a behavioral health professional for any mental health or substance use needs they might have as well.
Awesome. Thanks. Someone wanted to know, Campbell wanted to know, who are some of the main groups or organizations developing permanent supportive housing in the Denver area? Colorado Coalition for the Homeless is one of the largest ones. I feel like, Jacob, I'm sorry, I'm going to pass this one to you tonight if you have some thoughts.
Yeah, so there's a lot of groups, right? You have the Coalition for the Homeless, which I think is, of course, I'm biased, right? Is really unique in that we're doing two things. We're not only building permanent supportive housing, we're also advocating for more permanent supportive housing, right? So we're doing kind of both ends of it. There's a lot of different entities that are like ours, doing well, not quite like us, but who are building a lot of housing or advocating for more housing. So off the top of my head, Brothers Redevelopment is a great one. Mercy Housing is another really good one. And the city of Denver is honestly doing a lot as well, right? So you'll read about the city of Denver, just like we have in the past, purchasing motels, using them temporarily as kind of non-congregate shelter options, within the long-term plan of turning them into studio permanent supportive housing. So I would say those are some of the major people that at least I'm aware of off the top of my head.
Thank you. And we had someone in the chat mention that Together is opening a permanent supportive housing program in April for youth. So we do also see other models that are really specific to certain populations as well that have come up. So there's a question here. It's rather a long question about basically numbers about sheltering, sort of I'm going to try to summarize. I apologize, anonymous attendee, but essentially, like, sort of as a taxpayer, as a person in community, it's hard to know who's getting services. Is the same person getting services multiple times? Sort of like, is there any work to try to get all government entities to show real, honest reporting, or like, anything about reporting? I know, Jacob, you work closely with the city of Denver for outreach programs that we do, either like with other organizations or independently. Maybe you can talk a little bit about like some of the difficulties with the numbers and reporting, or better summarize that person's question than I did.
Yeah, I mean, it's a big question. It's a great question. The best answer I have is, and it's something that hasn't come up today, is something called HMIS, Homeless Management Information System. It's something you're going to find nationwide. There's different forms of it, but essentially it's a system that all homeless service providers go into and record services in. And the idea is, better service coordination, better reporting, and just like, I'm trying to think of the best way to say this. So let's say our outreach workers in the storm last week went out, they met, right? They met John Doe, they put them in HMIS, they got enough information to do so. And then John Doe ends up receiving services from a shelter or someone else a few weeks later. And he's expressing some confusion about, he's not sure who's helping him with his case management, what's going on. They're going to be able to see that he connected to an outreach worker. They're going to be able to reach out to us. We can talk about how we can best coordinate. So it's not just simply coordination of care of like, oh, they see we're providing that service, so they won't do it. It goes deeper than that, that they can also kind of help the person get reconnected to something that they may have gotten disconnected from. And reporting is just huge, right? So for all of our grants, a lot of the stuff funding we get, we have to run reports out of HMIS that show how efficient, ideally efficient, not inefficient, our programs are being with those dollars. And it helps track, right, other people who are receiving that same government funding, so that they can't claim John Doe as a successful, right, outcome, and we also claim that same person, right? It deduplicates that kind of thing. So that's really the best way that they try to keep track of that service and to kind of dollars spent and services provided.
Thank you so much, Jacob. We have a question from David that's asking about the implementation of the waitlist. So the waitlist started at Stout Street Health Center in January. So this is a pretty recent change, that some of the case managers and sister organizations are getting asked, how long the timeline is. and when walk-in appointments might resume. And so, Suzanne, can you answer David's question about what we think, at least at this point?
Yes. Right now, our wait list is a few months out with getting patients scheduled to establish care. Right now, I don't have an ETA of if we'll be getting rid of that wait list anytime soon. Like I said, it just started on January 16th of this year. However, if your patient is established or your client is established here as a patient, this has actually opened up more opportunities for them to be seen as a patient. So there's more opportunities for them to be seen across the board with medical and both dental. So we're hoping that that will have some improvement in some patient care that we've been lacking for a little while since we've been so flooded with a bunch of new patients day in and day out.
Thank you. We have a question from Colleen about thoughts about giving money or food to people who are experiencing homelessness.
Yeah, this is a really common question that we get. Food's never a bad idea. What I always recommend to people is keep, depending on the time of year, keep granola bars, keep bottles of water, right? It's obviously more of like a warm weather thing. Socks, wet feet is a huge, huge thing. I was out during that snowstorm last week. I don't know why. I went on a short vacation early this week, and it's like my whole sense of time got lost. My shoes got soaked. I was not wearing the right footwear. It was supposed to be waterproof. It wasn't. The water came in. My socks were completely soaked. Fortunately, I was able to go back to my vehicle, change socks, right? Our clients don't always have that luxury. So I could say keep socks, hats, gloves, that kind of stuff I think is the best to keep in the car to hand to folks. It's not that you can't hand them money. There's different groups that do different, they rate different cities on like, hey, should you give money? Should you not give money? The last I looked, which was a few years ago, they said Denver was not one of those that you should give money, that it's better to give them some of those supplies. If you have information on resources to refer them to that. And I'm also, a lot of the clients I've had over the years, do what we call fly a sign. And by no means am I going to hurt their business and say, don't do that. It's just what I personally recommend. And what I personally do is keep those other things in my car instead. And I make eye contact. I say hi, right? I humanize the situation, which I don't often think is done. I think people avoid that sometimes.
Suzanne, I'm going to follow up because we had a follow up on the waitlist question. It says, is case management enough connection or is previous medical connection necessary? So I think what they're asking is if someone's just in our system already as one of our clients, is that enough for them to be an established patient, or do they need to have an established relationship at the Stout Street Health Center with a doctor or a nurse or a specific person?
If we have built you a chart at any point in time, you are considered an established patient. So when your client comes in, or if a patient comes in and they want to register, we can look you up in the system and see if you ever engaged in services with us. This could have been a year ago, 6 months ago, 10 years ago. We can find you in the system, and then we'll be able to get you taken care of. And then the other part was about case management. So it can be a provider referring you to a case manager. And then also, as Jacob said, they do have those walk-ins at the Broadway building during those specific days and times for people to engage with case management. And to my knowledge, there is no wait for list for that. This is only for medical and dental. So.
Thank you. And so we have one last question, works out perfectly timing wise. We'll just do a quick wrap up after it. So the final question we have is, in addition to supporting your organization, how else can folks help? So what do you recommend to people? There's a great chat going on, people talking about where to get the cheap socks and how they personally provide assistance to people. But if either of you would like to recommend other ways that people who are on this session can help.
Yeah, I would say that I personally say myth busting is some of the best things you can do, right? So use the information that Alexis talked about to kind of debunk some myths that some people in your lives that come up in conversation might have about people experiencing homelessness, some of the stereotypes, this sense that, people are lazy or choosing to be homeless, or, they're all, mentally ill or drug addicts, or, some of that really negative language. I think debunking that's really important. I find the best way is through that ACE study that Alexis was talking about. I kind of explained that, like, hey, some folks who have had, the death of a parent, witnessed, domestic violence growing up, all these different things that can constitute an ACE score. You were exposed to violence yourself, different types of abuse. it physically alters the way your brain develops, and it really does change your ability to navigate what can be a very complex, right, societal structure that we have, and earning income and paying for housing and doing all these different things, and has shown to lead to dramatically higher rates of homelessness as an adult. So I try to talk about that because I feel like it humanizes people a little bit more. It kind of takes away the stereotype. And when people think about kids, right, adverse childhood experiences, they tend to have a little bit more compassion. So that, I would say, if you Google anything when you walk away from this, Google the ACE study. It's really fascinating. It can be a short read if you just read a couple paragraphs on it, and that really can be enough. It's very intuitive to then talk about. And just really quick, my favorite podcast always does a correction corner. I want to do a quick correction corner, and that there's a million housing providers I didn't mention, right? There's different youth housing providers like Urban Peak that are doing a lot. I saw there was a person out there who's doing a lot of youth serving organizations, St. Francis Center, Volunteers of America. Like, there's so many. So I just want to apologize for all the ones I forgot. It's tough getting put on the spot, but there really are a lot of agencies that are building and providing a lot of permanent supportive housing.
Suzanne, anything, or you don't have to? Okay. Okay, that's enough. Jacob, thank you for letting me put you on the spot for that and many other questions. I really appreciate it. Gabrielle, if you can share the last slides. Just going to once again promote our April session, which is on migrants and homelessness. So please do register for that and join us. The May registration will be up within a couple days. And then finally, on our last slide is just thank you so much for joining us. We know that not everyone chooses to spend their evenings, especially on a beautiful day like this, learning about homelessness, learning about how to help our neighbors. So thank you all so much for taking the time and energy to do so. We really appreciate it. And we hope to see you next month. Please do fill out the survey on this. We do really listen to your feedback and build these around what you all think would be useful. So thank you so much, and we'll see you next time.